Everybody. I am very pleased to be participating in such a prestigious symposium, and I am very pleased to be participating here with our Indian partners. I thank you, Dr. Shalini, Professor Kumar, Professor Rajiv, and all the faculty. Of course, I thank my professors, Professor Ines and Professor Hassanin, for giving me the chance. If you allow me to share the presentation with you, and we will discuss after. Moment, just can you see it now?
Not yet.
It's loading, I think. Yeah, yes.
Okay.
You can please put it in full screen mode.
Yeah, I will. Okay. Yeah. So let's ask the question why hepatogastroenterologist would be presented in a symposium for diabetes. Because in many lectures given by the professors, we are now aware about the multidisciplinary approach of our patients, and there is very big amount of patients in our GI clinics who are originally coming to visit us from the diabetes or the endocrinology clinic with long-standing GI complaints. And maybe also your patients in your own clinics, they are complaining all the time from GI disorders. And you, of course, as internists, before becoming endocrinologists and diabetologists, you would try to explain to them why those GI complaints are coming from. So I come here to shed some light on a very underdiagnosed and undernoticed problem, which is the exocrine pancreatic insufficiency and its relationship with diabetes mellitus. This is going to be my agenda, and let us not waste time in it. You will know it all. This is the pancreas. Of course, the pancreas is spread between two specialities and does not know who is the father. Is it the endocrinologist? Because pancreas is an endocrinal organ, and when an endocrinal society wants to make a logo for itself, it will definitely pick the pancreas as their logo. On the other hand, there is the gastroenterologist, of course, who thinks of the pancreas as, because of its exocrine function, that is, when he performs another society, the gastroenterology, he will also use that pancreas as a logo. So there is some debate about whether the pancreas is an endocrinologist problem or a gastroenterologist problem. So I said to myself, why not make this happy marriage between the endocrinal and the exocrinal part, between the endocrinologist and between the gastroenterologist. So my introduction, of course, all of you know that the pancreas is an exocrine and endocrine gland. The exocrine part is the most important part in our digestion. Actually, our digestion depends primarily on the pancreas, and if you don't have a well-functioning pancreas, unfortunately, sir, you will not digest, because the pancreas is responsible for the digestive enzymes that can digest carbohydrates, fats, and the proteins, and it neutralizes the acidic chyme that is coming from the stomach. Moreover, the exocrine pancreas, the part I'm speaking about, comprises 85% of the pancreas. So it is the majority of the pancreas is an exocrine gland. So how they interplay together? Do they have something to do with each other, or they are just neighbors in the same neighborhood? No, sir, they have very much interplay to do with each other. Endocrine islet cells hormones regulate the ductal and acinar cells of the exocrine activity. How is that? The insulin is tropic or trophic T to the ductal and acinar exocrinal activity. How is that? Rise of insulin and other pancreatic islet peptides like amylin, C-peptide, and urocortin 3 following the postprandial glucose rise will actually stimulate the exocrine pancreatic function to start performing its job. Also, the increase of glucagon will do the other way around. It will depress the pancreatic enzymes and juice secretions. While the ductal and acinar cells, they affect the physiology of the endocrinal islet cells through the cytokines and growth factors that they can secrete. So, what is the definition of exocrine pancreatic insufficiency? It is the inability of the pancreas to secrete enzymes and bicarbonates for the action of on the intestinal lumen to accomplish the normal digestion of food, like I formerly mentioned. How is that be done? The mechanisms of exocrinal pancreatic insufficiency can be by abolishing any point of the digestive chain of the exocrine pancreas, by insufficient activation of pancreatic secretion, by damage of the pancreatic cells, which reduces the production and secretion of pancreatic juice, by asynchrony. Asynchrony means that the food is present in the intestinal lumen at a time where the pancreatic enzymes are not present, and the other way around. The pancreatic enzymes will reach the intestinal lumen when the food is not there at that time. And this happens, for example, with bariatric surgeries or the bypass surgeries. And lastly is obstruction of the pancreatic juice by any problem that obstructs the pancreatic duct. So what's the relationship between exocrine pancreatic insufficiency and diabetes? Here is the first fact. 50% of patients with type 1 diabetes, they have exocrine pancreatic insufficiency. So among every 2 patients with type 1 diabetes, there is 1 of them already complaining of exocrine pancreatic insufficiency. And why is that? Because lack of the trophic action of insulin and possibly glucagon and somatostatin on acinar cells, like we said, involvement of the exocrine tissue in the same autoimmune destruction of the islet cells. The autoimmune cells who are going to destroy the islet cells will not leave the exocrine part alone. It will destroy the exocrine pancreas as well as the autonomic diabetic neuropathy leading to enteropancreatic reflex impairment. It means that when they have this kind of autonomic neuropathy, those reflexes that allows the exocrine pancreas to start to secrete its juice is going to be impaired. And lastly, the hypoxic sufferance, like any diabetic having a micro and macrovascular disease, all his tissues are hypoxic, as well as his pancreatic tissue, because of the microvascular damage. What about type 2 diabetes? Type 2 diabetes, they have 35% of patients, they are having exocrine pancreatic insufficiency. I mean, every 3 patients with type 2 diabetes, 1 of them is suffering from exocrine pancreatic insufficiency, and this is because of the autonomic diabetic neuropathy and the hypoxic sufferance theories only. So what are other causes? Of course, you know it better than me. Chronic pancreatitis, pancreatic malignancy, congenital diseases like cystic fibrosis, any disease that can obstruct the pancreas. Non-pancreatic causes like celiac disease, it's a very common, and celiac disease is common in type 1 diabetes as well. We know it very well. Crohn's disease, autoimmune pancreatitis, Zollinger-Ellison, and surgical procedures that will make the asynchrony between the pancreatic juice and the presence of food. So, according to that, there are proposed subgroups of pancreatic exocrine insufficiency. They are divided according to the etiologic factor. We say that there are some factors that are definitely to cause pancreatic exocrine insufficiency, like pancreatectomy and chronic pancreatitis and cystic fibrosis and so on. Others that are possible to cause pancreatic insufficiency, like gastric surgeries or mild chronic pancreatitis, or post-pancreatitis or Whipple disease, and things that are likely like the functional disorders like the irritable bowel syndromes, but they have less amount of causing exocrine pancreatic insufficiency. So what is the prevalence of exocrine pancreatic insufficiency? Unfortunately, it is unknown. Why it is unknown? Because doctors, they don't think about it, so they don't search for it. So you diagnose is very, very less than it should. So you cannot say the prevalence of a disease that you don't diagnose. But it has a very high percentage among the diseases, as we said for our lecture today, that in type 1 diabetes 50%, and in type 2 diabetes it is 35%, and like patients with chronic pancreatitis, it's almost with time that they must develop exocrine pancreatic insufficiency. What about the clinical presentation? How could we suspect exocrine pancreatic insufficiency? Unfortunately, the symptoms of exocrine pancreatic insufficiency are very common, and they do not almost occur unless there is less than 10% of the exocrine pancreatic function. The most common is steatorrhea. This is a very late presentation of exocrine pancreatic insufficiency, but what is commoner than that and occurs a little bit earlier than that are the symptoms of dyspepsia, occasional diarrhea, meteorism, distension, malabsorption, and maybe while examining the patient, you would find that he's having some sort of vitamin deficiency, of course, mainly the vitamin, which are fat-soluble vitamins like vitamin A, D, E, and K. Malnutrition can lead to sarcopenia, and of course now we are speaking about sarcopenia very much, and we are seeing that even obese patients, they can be sarcopenic. So they don't need to be losing weight to become sarcopenic. They can simply be malnourished to be sarcopenic. Also, there is increased incidence of all other comorbidities like osteopenia and osteoporosis and non-traumatic fractures, like the increased risk of cardiovascular events. Already diabetes is a cardiovascular event. The presence of exocrine pancreatic insufficiency may multiply this risk of cardiovascular event, and of course there is some sort of immunocompromisation, so they are very prone to concurrent and intercurrent infections, those patients with combined diabetes and exocrine pancreatic insufficiency. So how can we diagnose it? There is combination of 2 out of 3 symptoms of maldigestion or malabsorption, indicator of a malnutrition, and a positive result of a non-invasive pancreatic test. How is that? This is the way it goes. If we have an exocrine pancreatic insufficiency, definite etiology, like we said, severe chronic pancreatitis or total pancreatectomy or cystic fibrosis, I don't need any diagnostic test. I don't need any kind of investigations. This is a definite exocrine pancreatic insufficiency. And of course, those patients will definitely develop also diabetes, what we all known before by the pancreatogenic diabetes mellitus or type 3C diabetes. This is a term that we use less nowadays. What about the possible and unlikely? Those are the patients that they need some investigations. As we said, clinical presentation, nutritional markers, and indirect pancreatic tests. If we have the clinical presentations and the nutritional markers, or the clinical presentation and the indirect test, or the nutrition and indirect, we say that it is exocrine pancreatic insufficiency possible to say it. Unlikely if we have only the indirect test positive without any nutritional marker of deficiency. What are the diagnostic tests of exocrine pancreatic insufficiency? We know that we have some considerations. Direct methods should be highly sensitive and specific, but they are invasive, expensive, and very time-consuming, and not readily available, and unfortunately variable among centers that prevented their standardization, and that's why they are not very useful. What about the indirect methods? They are less sensitive, but they are less costly, and they are, of course, easier, and unfortunately are not very widely available, precise, readily reproducible diagnostic technique. That's why exocrine pancreatic insufficiency is underdiagnosed. What are the direct methods? And we can see that they are, all of them are very different, like the 72-hour fecal fat estimation, or what's called the coefficient of fecal absorption. This is the gold standard, but it needs 3 days collection of stool, 100-gram standard fat diet for 5 days, and you have to stop therapy. And after all that, it is not specific. We have the endoscopic pancreatic function test, which was useful only in early cases, but it is very time consuming because you have to collect the duodenal juice for a whole 45 minutes during an endoscopy. This means anesthesia for 45 minutes, endoscopy for 45 minutes, collecting duodenal juice for 45 minutes. And unfortunately, after that, you cannot quantify the volume output because this only 45 minutes and the patient is not eating and you cannot quantify. What about the cholecystokinin secretin stimulation? It is the gold standard in scientific evaluation. I mean in research and in research centers, because it's invasive and complicated. And lastly, of course, the secretin MRCP test. It's by giving secretin and having serials of MRCP images, 3 minutes, 7 minutes, and 10 minutes afterwards. And it needs more validation, and it is subjective, and it needs precise timing of the serial imaging, and that's why it is not very common, and it's almost uses were in acute and chronic pancreatitis, and they were not validated in other etiologies of exocrine pancreatic insufficiency. What about the indirect pancreatic function test? The most common and the most widely used, and the one that I usually use in my clinic, is the fecal elastase 1. It is the gold standard. It's advantage that it is most widely used. It's non-invasive, single sample. You don't need fecal collection. Does not require stoppage of therapy. In fact, you can you use it once, and you can give the therapy. Then you can monitor it again by ordering another sample, and it is not very expensive. It's highly sensitive. Only disadvantage that is not very nice results when you have liquid consistency of your stool, because it cannot be readily measured, and there are other potential causes of false positive like the bacterial overgrowth, and of course like calprotectin test in diagnosing GI disorders. It has this gray zone between 100 and 200 micrograms. These are a gray zone. It is not a positive test. The positive test is above 200, less than 100 is a definite deficiency. What about 13C mixed triglyceride breath test? Of course, we know there are plenty of breath tests to diagnose malabsorption syndromes. One of them is the 13C mixed triglyceride. It is by giving a diet with triglycerides, rich in triglycerides, and with 13C carbon particles in it, and then you measure it in the breast. It is simple, it is non-invasive, it can be useful to monitor the treatment response. The disadvantage is the false positive, because any patient with chronic liver disease or chronic lung disease will have a false positive result, and it is also non-specific and low sensitivity in the mild forms of exocrine pancreatic insufficiency. What is the treatment? What is the therapy? After you have this clinical suspicion and you perform the indirect test and you can find it that there is deficiency in the fecal elastase, What are the indications of pancreatic enzyme replacement or supplementation? Indications, of course, are weight loss or steatorrhea and the persistence of symptoms of dyspepsia, diarrhea, meteorism, and malabsorption of proteins and carbohydrates, and of course, after exclusion of functional disorders. Of course, it has no benefit in pain management in cases of chronic pancreatitis. We are only speaking about the supplementation for improving the digestion and the nutritional status of the patient and maybe control of his steatory. The goals of therapy, the main goal is to supply the patient with optimal amounts of lipase to reach the duodenum with the delivered food. The currently available forms will maybe eliminate the azoturia, which is the protein malabsorption, whereas it will only decrease the steatorrhea, which cannot be totally corrected. The general measures, of course, is a lifestyle modification like any disease. Let's like say avoiding fatty food, limitation of alcohol intake, cessation of smoking, and consumption of well-balanced diet, and maybe refer the patient to a dedicated nutritionist to plan the diets with your patient. Vitamin supplementations, of course, primarily the fat-soluble vitamins A, D, E, and K. And of course, the gold standard or the mainstay is the what's called the PERT or the pancreatic enzyme replacement therapy. Long-term monitoring will focus on correction of nutritional deficiency and treatment of positive diseases if possible. And we can see here it is like 4 pieces of a puzzle: lifestyle, PERT, follow-up, and diet. Endpoints of treatment are normalization of fat absorption and correction of nutritional deficiencies. The typical indications for initiating the PERT is the progressive weight loss and steatorrhea, and the efficacy by increasing or increased by higher enzyme doses, by enteric-coated supplement, and of course by suppression of acidity, so not to destroy those enzymes before reaching the duodenum, and administration of therapy during food. We always instruct our patients to take the pills during eating, while they are eating, in the mid of their already of their meal, so that when the meal reaches the duodenum, the pancreatic enzymes will reach the duodenum by the same time, and by that we can guarantee the synchrony between food and the activated enzymes. How we can measure the improvement? Of course, by the fecal elastase or by the coefficient of fat absorption and the serum nutritional parameters and the abolishment of GI symptoms and improvement of the quality of life. There are 6 approved agents by the FDA. Lipase plays the paramount role in the therapy. There are combinations of amylase, protease, and the lipase. These are the approved agents. Of course, many of you may be aware of some of them. I don't know about India, which of them are present. And in fact, in Egypt, we had the creon, and afterwards it was stopped from being here. Problems, of course, with with bringing it from outside. And now we have 2 companies in Egypt. They are making the pancreatic enzyme formulas, and they are present in the market nowadays. These are the different concentrations, of course, and we, as I said, we start by titration of the dose until we reach the optimal result with our patient. And this is a form of the syrup in patients with pediatric population, like those with type 1 diabetes. And of course, the consideration is, as we said, administration with means, increase the dose depending on the lipase, improvement of the body weight and clinical symptoms, and less stool fat content. Of course, you have to allow several days, maybe a couple of weeks, before moving on to the new dose. Of course, should be enteric coded. And there is the technology of many microspheres that makes the birth effect much better. Of course, at least we start with 20,000 units of lipase, then we can increase the dose later on. The adverse effects of pancreatic enzyme replacement are very trivial. Some of them are just some abdominal pains and cramping, and they can go away after a while, to less extent that they can cause some cough, some dyspepsia. Unfortunately, they can also cause some diarrhea, but all of those are transient and not much of a complication. But you have to cautiously use it in patients with renal dysfunction and hepatic dysfunction. Of course, not very well tested among pregnant females. In a capsule, there is so much interplay between exocrine and endocrine pancreas. So exocrine pancreatic insufficiency is very, very, very common among diabetes. We said half of type 1 and 1/3 of type 2 diabetes. It is largely a clinical diagnosis. So all of us, diabetologists or endocrinologists, seeing so many diabetic patients every day, we have to suspect exocrine pancreatic insufficiency as a cause of the GI complaints of our patients. It's not necessarily that it is a bacterial overgrowth or the effect of metformin, or that is having functional GI disorders like irritable bowel syndrome or so. Please think of exocrine pancreatic insufficiency and search for deficiencies before the era of steatorrhea. Correct the vitamins like A, D, E, and K. And of course, the mainstay is the pancreatic enzyme replacement therapy that depends mainly on lipase, at least 20,000 units, and you can increase it every couple of weeks according to the response. And thank you very much.